I will introduce our first speaker. Our first speaker is a medical nephrologist at the UTE University. Likewise, he is the medical director of critical nephrology at Dial Neph. He is the head of nephrology department at Enrique Garces Hospital. He is a professor of medicine at the Central University of Ecuador, and currently he is the president of the Ecuadorian Society of Nephrology. Colleagues, let's all welcome Dr. Dario Jimenez from Ecuador, who will talk on rationale and evidence for hemoadsorption in poisoning and drug overdose.
Good afternoon, everyone. It is a pleasure for me to be here. The theme of my talk is about rationale and evidence for hemoadsorption in poisoning and drug overdose. You have my no work.
This one is the next page.
Okay. You have my email at the bottom, so you have any comment, any question. And this is my disclosure. And I want to start. I want to start showing you quickly the different modalities, the dialytic modalities. The first one is the diffusion, which is to be a technique very easy to learn and very easy to practice also. And the move of substances. Sorry. Yeah, this is diffusion. Very easy to learn and very easy to practice also. And the move of substances is from a side of higher concentration to side or to less concentration. Of course, this not allow the passes of the middle molecules. Of course, neither the albumin. But always we like sometimes more seductive our treatments, and of course more efficient, like convection. This modality allows us to pull the substances through ultrafiltration, and you can see that it's more efficient in the removing hard molecules, and of course it doesn't pass the albumin. Finally, the modality that we are interested in this conference, which is the adsorption. I represent as an intelligent magnet because it allows us to remove the molecules in the one clear from the blood, and you can see as the blood pass through resin molecules, and the middle and the inflammation molecules, you can see here, are absorbed inside the resin by different mechanisms. Like to force the van der Waals or molecular savings, etc. Due of these characteristics, it does not regulate metabolic or electrolyte disorders. Therefore, sorry, yeah. Thank you. Therefore, is a complement to other modalities of dialysis, for example, convection or diffusion. But I would like to clear up the terminology, and because we have been using the term of hemoperfusion in an indiscriminate way, inclusive today. However, I think that the correct name is adsorption because it's the dialytic modality. But hemoadsorption is when the technique allows the passage of total blood through the cartridge with sorbent material, and when only the plasma passes through a cartridge, the correct name is plasma adsorption. Here is necessary a plasma separation first. The best example is CPVA or DP mass. Okay. Showed here, so it's necessary standardization of concepts, and this article is appropriate for this. What about intoxications? It is our last publication, which was 1 year ago. I want to show that the total of patients in the ICU in my country, in Ecuador, 17% require any kidney replacement therapy, but 7.2% were treated with adsorption, mainly due to poisoning. But when the question here is, when start this treatment for acute intoxication? And it is a great question. And I think that we are in the initial steps. There aren't studies to know when to start. I could say that we can use the adapted algorithm of Professor Ganon. So, in which you have a situation that threatens of the life of the patients, we must answer many questions to know if we use it or not an extracorporeal therapy. If there is not an antidote, if the clearance of the toxic is no greater than 4 ml per minute, if the volume distribution is less than 2 liters per kilogram, so in this point it's necessary to know the protein binding percent. If it is less than 80%, then we will need the molecular weight. And you can see that the absorption has an indication for molecules between 10 and 5,000 Daltons. And if the toxic weight much more, then plasma exchange would be the adequate indication. Even still, the toxic has between 80 to 95%, then the plasma exchange is the indication. And if the protein binding the toxic is 80 to 95%, the adsorption is the best treatment in order to clarify this toxic. But if the intoxication is by toxic with protein binding over 95%, maybe plasma exchange is the better option. But if the intoxication not threatens life of the patient, or for example, there are an antidote, and the other answer are yes, the extracorporeal technique is not indicated. Now, I think there are two groups of the different intoxications. The first one is endogenous intoxication, for example, in rhabdomyolysis, where myoglobin is over levels blood. For example, liver failure with bilirubins and ammonia, or kidney failure with middle molecules similar to pecresol or leptin, or another disease, for example, multiple myeloma and thyroid storm, for example. And the second group is the exogenous intoxication, for example, drugs, pesticides, organophosphates, paraquat, or antibiotics. But the common disease in this type of toxics principally is the inflammatory process. The inflammation and the cytokines present in all of these diseases may be the target of the remove with the hemoadsorption in order to alleviate this disease. What about evidence of rhabdomyolysis? This is a 17-year-old patient. Patient with severe rhabdomyolysis, 3 assisted cardiac arrest. The first intention from intensivists and traumatologists was to disarticulate the lower limb because the injury was from the inguinal region. He was in anuric AKI, acute kidney injury. So I started CRRT and placed an hemoadsorption cartridge with HI-330 cartridge in series by 2 sessions. 4 hours per session, so myoglobin descent from 5,000 to 700. No more cardiac arrest, and it was not necessary to amputate the leg. AKI was resolved in 5 days of CRRT. This is another patient, 56 years old, patient with motorcycle accident and with crash syndrome, plus sepsis by urinary tract infection. Again, I select hemoadsorption cartridge 330 plus CRRT. But what is the rationality for using hemoadsorption in rhabdomyolysis? Well, we know the myoglobin weighs 17,000 Daltons, and the inflammatory molecules are 24,000 Daltons. No? If we apply this to the molecular sieving of HA filters, you can see that hemoadsorption 130 could be used. But other inflammatory molecules are larger size are present in these patients, in this type of patients with sepsis. So choose HA330 cartridge. Creatine phosphokinase, CPK, made up of 2 subunits that would weigh at least 40,000 Daltons each unit. So will be difficult. The pure CPK, but it is not necessary because it does serve as an excellent clinical marker of remission of disease. While as we purify myoglobin and inflammatory products, CPKA show with similar to biomarker the remission of disease. This is another case which we place as relation to miscellaneous situations. It's another case of endogenous intoxications is a thyroid storm. You can see the clinical evolution, the patient with very important complication with hemodynamic commitments and cardiac and pulmonary congestion into the ICU. She was in vasoactive drugs and mechanical ventilation, who did not respond to the pharmacology treatment in the first intention. For example, propranolol, metomazole, intravenous steroids. And knowing that thyroid hormones have a high percent protein binding, we decided to use HA230 cartridge, which demonstrate an excellent and effective treatment option, especially when first line drugs treatment has failure. 2 sessions, hemoadsorption sessions, and look how the heart rate and stroke volume were improving. The hormones were decreasing until ICU discharge. In this slide, you can see the video. For example, another indication for HA330 cartridge. This is she is a gestant patient with eclampsia, liver and kidney failure with accumulation of endogenous substances. The treatment was included in hemodiafiltration online plus hemoadsorption with HA330. Because in my country I don't have the BS330 in order to apply to TP mass, but we also use this cartridge because demonstrate that in this treatment decrease until 30% of bilirubin's blood levels. We also use hemoadsorption as an important method of inflammatory molecule removal in hyperinflammatory syndrome, in which you can remove cytokines. So in times of COVID, when the patient had a high risk of entering the mechanical ventilation, we performed hemoadsorption early. And in about of 10 patients with high levels of interleukin-6, interleukin-18, ferritin, that we treated in this way, we avoid their admission to mechanical ventilation. Regarding COVID, we carried out a study with 24 patients that we show this in Vicenza course in 2020. And we made a comparison of intermittent hemoadsorption with Jafron cartridge versus continuous hemoadsorption with cytosol cartridge. And intermittent hemoadsorption was used as the ASEAN guide recommended in the 2-1-1 scheme, and continuous hemoadsorption was 48 hours of treatment with 2 filters, 24 hours each filter. And the mortality of these patients were, with intermittent hemoadsorption was 38%, and versus continuous hemoadsorption was 50%. But at the end of intervention, the total mortality was significantly less in the intermittent hemoadsorption. And also we compare the cytokines removed and the ferritin levels. They were in favor of intermittent hemoadsorption. If you take into account the costs, there was a saving of $1,000 per treatment. So, and then we only use intermittent hemoadsorption indeed continuous hemoadsorption. This, in another miscellaneous treatment, this is a case of macrophage activation syndrome. In the context of a pediatric patient, 4 years old, 20 kilograms, with systemic juvenile arthritis, the pediatric rheumatologist asked me to perform plasma exchange. But in the first session, I didn't have good results, and plasma exchange is very expensive in my country. So we offered to carry out hemoadsorption with a cartridge HA330 and at a different time. And you can see the blood flow is adjusted for the pediatrics indication, 70 ml per minute. I don't know if it is it of label or contraindicate, but it was rational for this small patient. And we placed the filter for 2 hours in each session, and we did 2 sessions. And you can see in the next table how the ferritin and interleukin-6 levels decrease. The patient was discharged with a good response and healthy. I am not going to stop here because the next speaker, Dr. Omar, told about this intoxication of this type, organophosphate, but I just want to show the management protocol in my hospital. The patient does not spend more than 2 hours in the emergency room and immediately is transported to the ICU. We begin hemoadsorption treatments each 8 hours, at least 3 or 4 sessions according to clinical response, based principally in atropine dose and acetylcholinesterase levels. This way, it can be seen that from the sessions, the atropine dose decreasing in the second session, and acetylcholinesterase levels improve, demonstrating toxic elimination. A third session achieves a better results. 72 hours after and 96 hours after, because the good clinical response, the patient is ICU discharged. But I need to show you that another rationality for use hemoadsorption in relation for cost benefit. In this case, we took advantage of this clinical case in order to evaluate the cost benefit. And you can see that you have saved more than $3,000 US when you treat with hemoadsorption rather than general detoxification. This is also a rationality for use of hemoadsorption in this intoxication type. The time is very important also. What is the ideal time to start hemoadsorption in intoxication? So earlier is better, but what is earlier? In this article, in this research article, I need to show you that they comparate the survivors and deaths, and the time may be 26 hours in favor of benefits of hemoadsorption in different treatment of toxics. In another studies also receive many sessions, and earlier is better than or more efficient than single hemoadsorption in organophosphate poisoning, for example. In ertapenem therapeutic intoxication in relation to antibiotics, in this patient with a diagnosis of toxic encephalopathy for treatment, We made the hemodiafiltration online plus hemoadsorption in the first time with HA330 because the patient had the sepsis also, and then hemoadsorption alone and a patient with renal transplant many years ago, and it was necessary only 3 sessions for hemoadsorption in order to improve the neurological symptoms. And this is the first case report with hemoadsorption treatment in intoxication by ertapenem with neurological disease. And you can see in this meta-analysis, the patients report recuperation with another types of treatments between 8 and 14 days. And in our patient, the recuperation and the recovery was in 4 days. Is another hemoadsorption is a easier technique. You know the presentation show before, so I don't stop here. But it's necessary only improve velocity with a blood pump, pass to blood through the filter and return to the patient. And combined with therapies also. You can put the filter pre or post filter. Sorry, this slide is in Spanish, but you can make English. So to conclude, the hemoadsorption for acute intoxication is feasible, easy, safe, effective, manageable, and efficient. And this is my working group in DIAL-NEF, Nephrología Crítica, and the name is the Schemming Group. And the last year in Vicenza, we had the first meeting with the extracorporeal therapy group in Latin America. So this is my information for you, and thank you very much.
Okay, thank you very much, Professor Jimenez.